Thank you, Prashant, for sharing the session. Now we will move on to the next session. Next section is something very interesting. We have three major topics on the session. To chair the session, we have two eminent faculties from Trivandrum, Dr. Sunil Prashop, Senior Consultant Diabetologist, Medical College Trivandrum, and Dr. Ramesh Gomas, Consultant Endocrinologist from Medical College Trivandrum are there to chair the session. Over to Sunil.
And the next section is on diabetes in a diagnostic dilemma. And the session is going to be dealt by Dr. Vinod Mittal. He's a very, very famous speaker. He's from Delhi. I know him personally. He's a senior consultant diabetologist and head working in Delhi Heart and Lung Institute. He has done several post-graduations, diploma programs, fellowships, and he is a very renowned speaker. He has got a vast clinical experience in the field of diabetes for more than 30 years and has received many honors and awards. Over to you, sir.
Yeah, thank you for those kind words.
Yes. Thank you.
So, good afternoon, everyone, and I convey my thanks to Dr. Shabir for giving me this opportunity to share my views and thoughts on diabetes in young, which is a very important, a problem in our day-to-day routine, and it's rising day by day. So there's always a diagnostic dilemma in a way. All diabetes in young people are not type 1. There are many possibilities. Type 2, MODI. So there are a number of, I would be discussing, some cases, and that would make us understand, how to differentiate between different types of diabetes in young. So there is a increasing prevalence of diabetes in young world over, and mainly, yes, type 2 is also increasing because of this modern culture and increase in the prevalence of obesity. So basically, the prevalence of diabetes in young is increasing, and the challenges are that diagnostic dilemma is one. Then cooperation and compliance is a major issue, because this younger generation, they won't cooperate in taking medication. They don't take their problems seriously. But at the same time, we have to understand there have been many studies, especially from All India Institute of Medical Sciences, and there is a study national level that diabetes in young, yes, the most common is type 1, but yes, even type 2, MODI, FCPD, etc. are also there. Now, important point they have noticed in this registry is that the complications in these people are more common compared to adults, and they're more severe. So this is an important thing, that we have to address diabetes in young more aggressively, but correct diagnosis is required, and we have to have a patient-centered approach. So the first case is a 15-year-old boy came to us with history of recurrent boils for 2 months, history of polydipsia, polyuria, polyphagia, 1 week, fever, and weight loss of 4 kg in a month. Sugars were very high, A1C 10.3%, urine ketones plus, a family history of diabetes, father is diabetic. Examination, height 162, BMI 25, no acanthosis nigricans, like no signs of insulin resistance. C-peptide 0.2 on the lower side of normal. Anti-GAD more than 10 units, normal is less than 8. So basically this boy was managed initially with antibiotics for boils, insulin infusion, and was discharged on basal bolus insulin. We were not in a hurry to make a diagnosis on this patient. When patient revisited after 10 days, the C-peptide levels had risen from 0.9 to 0.2 to 0.6. Sugars came to normal. Then we reduced insulin, and since a patient was having a family history of diabetes, we also started patient on metformin. And to our surprise, next visit, the sugar remained normal, and we had to even stop insulin. So this is basically a case of a flatbush diabetes, where even type 2 diabetic patients, we can see here, even type 2 diabetic patients, when they have diabetes for the first time, and it can be very severe. Sugars can be very high, ketones can be positive, family history may be there, and some small antibody titers around 10, because for type 1 it should be more than 18, may be there. So what I want to say, that despite of ketones present in a person, in a boy, we should not be in a hurry to make a diagnosis, because these, some of them may be a type 2 diabetes despite of ketones plus. And there are four types of flatbush diabetes: ketosis prone diabetes, that is, when antibodies are present, and the beta cell function is, that is, insulin is levels are very low. Second is idiopathic type 1, when both are absent. Type 2, yes, beta cell function is there, C peptide levels may be very low because of glucotoxicity, and they may be ketones, but then later on when you give treatment, C peptide levels rise. And antibodies are generally absent, but in type 2, around, say 15% of the patients, they may be there, but the levels are not very high. And of course, there's another category which is LADA, where there's some amount of beta cell function is there. Antibodies are also there, but these people do not, survive on OADs for more than 6 months. Like insulin is required after 6 months of treatment. Now we come to case 2. So this case 1 was basically type 2, presented in ketosis. Now other is case, 18-year-old lady had type 1 diabetes at the age of 8 years, was diagnosed as type 1 diabetes, on insulin treatment, on basal bolus regime, well controlled till last 1 year, A1C 7.2 on insulin. Now this time, there was a UTI, and she's been having UTI recurrent for last almost 2 months on antibiotics. Fasting plasma glucose 180, postprandial 282, A1C 8.5%, BMI 26.5. On examination, BP was okay, a little on higher side, you can say, and skin tags were present. All other system examinations normal. C peptide 0.3. So again, it's on the lower side of normal. Cholesterol 219, triglycerides 182, LDL 128. Any problem? Am I audible now?
Yes, sir. Yes, sir. Yes, please.
Yeah. Okay. So HDL 38. So basically, it has been reported, there are some cases of double diabetes when patient starts with type 1 diabetes, and as the child grows older, because of this Western lifestyle, these children also try to, gain weight, and then they develop, mild hypertension, dyslipidemia, and some signs of insulin resistance. So what I want to say, that these people, type 1 diabetics, later on may tend to develop double diabetes, and then we need to add metformin in these children. So this is another important point we have to understand and remember, that type 1 will never remain only type 1. Maybe they develop features of insulin resistance later on, and we have to address this insulin resistance. So this is a second case. So basically, type 1, if we take, is, onset is less than 20 years, no family history, C peptide either absent or very low, anti-GAD antibodies should be more than 30. The levels are very high. And after treatment also, C peptide levels won't decrease. Like in our first case, C peptides were low, but on treatment, then later on C peptides increased. So that means, basically beta cells were suppressed because of glucotoxicity. And when glucotoxicity was addressed, there was normalization of beta cell function. Then LADA is basically late onset adult, latent autoimmune diabetes of adults. So this is generally after 30 years of age. It's a slow onset, but patient cannot remain on OADs for more than 6 months, and ultimately patient require insulin. Type 2 diabetes, definitely there are features of insulin resistance, and C peptide levels are generally high, but if there is a glucotoxicity, they can be very low levels, and antibodies are absent, but in 10 to 15% cases, as I told you, may be present, but the levels are low, and these people are well controlled on metformin and other OADs. Now there is another case, third case, case 3, 15-year-old girl having UTI for last 10 days. History of complaining of all features of hyperglycemia, polydipsia, polyuria for 10 days. She was detected to have diabetes at the age of 13 years and was put on insulin treatment. Presently, her fasting is 156, postprandial 256, A1C 9.2, ketones absent. Family history, mother is positive. She is lean, BMI 20, no features of insulin resistance, vital normal, systemic examinations normal. So such patients also we come across, and generally these patients, since family history is there, but ketones are absent and overall patient is well maintained. Overall, like BMI is not very low. So these patients are generally taken as either type 1 and they are continuing on insulin, or by doing antibody titer also this may be absent, and the C-peptide levels tend to be normal. So it's a little confusing state, and these children continue to be on insulin. But one thing I would like to convey here is that since mother is having a positive family history, and in Modi we have generations, 3 generations can have diabetes, and patient on insulin also is not well controlled, we should give at least think of a possibility of Modi. So this is one another case, interesting case. Children, a 13-year-old girl having diabetes at the age of 13 years, say 2 years back, on insulin, still not well controlled and having UTIs. So we should give a thought process that it may be something else. So other lab investigations here, C-peptide was one, so it was normal. So clinical diagnosis, as I told you, may be Modi in this patient, and when pedigree charting was done, we can see here, this is the patient. Her sister was also found to be diabetic. Mother is a diabetic. Then all mothers, side aunts are diabetic, and maternal grandmother is also diabetic. So here 3 generations are having diabetes. So we should suspect that it may be Modi, and Modi patients will not respond well to hormonogenic diabetes to insulin, and these people respond well to sulfonylureas. So this is only one small, like interesting fact that even Modi is not that uncommon. We should at least give a thought process. A child on insulin, not getting well controlled and having some abnormal features, we should do at least a pedigree charting, and then later on, if we really think that it is required, we should be doing genetic testing. So this patient, we started the patient on 2 milligram of glimepiride, and we can see there was a good control on A1C. So what I want to convey that some patients who are on insulin and they're thinking they are type 1, they remain as on insulin, and we keep on giving high doses, possibility of Modi should be thought of, and especially when age is less than here like in this patient. One second. So here, as per the Tattersall-Feazan criteria, age should be less than 25 years. It's autosomal dominant, 3 generations involved, absence of ketosis. It can be controlled with sulfonylureas only without insulin, but genetic analysis is a must for the diagnosis. Clinical features, these people are lean, and there are almost 14 types of Modi, and the commonest is Modi 3 in India, which is NF1 alpha defect, but it can be NF4 alpha, and then even glucokinase gene Modi 2 defect and RCAD. So number of other kinds of Modi are also can be there. So these are different types. I will not be going into detail. So I have presented 3 cases till now. One was type 2 flatbush ketosis prone type 2 diabetes, where a boy presented with diabetic ketoacidosis. The second was a case of double diabetes, and third I presented a Modi. Now this is a 4th case, 23-year-old male, diabetes for 2 years, and he's been having recurrent pain abdomen, passing oily stools off and on. Family history of diabetes is there. Non-smoker, no consumption of alcohol, He's on OADs for 2 years, poor glycemic control, fasting and postprandial values are very high. A1C is 8.2. On examination, BMI 19. So he doesn't, I mean, like typically he doesn't, fit into either type 1 or type 2. Ketones are absent here. And ultrasound, there is a grade 1, a fatty liver. So such people generally, when young people come to us, we think of only type 1 or type 2. We never think beyond type 1 or type 2. So that's an important thing we have to understand. And in this patient, there's a very clear cut, history of loose motions and, oily stool. So that's very important thing, which goes in favor of FCPD. So in this, you do only an ultrasound, or maybe, sometimes you can go for ultrasound. So in this patient, when, just a moment, yeah, I don't know why X-ray is not coming. So X-ray showed calculi at the level of T12 and L1, a typical case of FCPD. Now, management here is important in a way that normally we restrict, calories, but in FCPD there is a malabsorption, there is a, exogenous pancreatic tissue may also be involved. So you may need to require to give uh, high calories, and patient they are ketosis negative. Ketones bodies in urine are negative, but they are insulin dependent. They cannot be controlled because pancreas is destroyed, and they may also be required to be given pancreatic enzymes. So it's a typical fibro-calculous pancreatic diabetes, where generally it's more common in south part of India, in China, in Chennai and Kerala. And diagnostic criteria: tropical country, recurrent pain abdomen, steatorrhea, and abnormal pulmonary pancreatic function test. X-ray abdomen shows calculi, and ultrasound is very important. There may be, pancreatic duct dilatation, atresia. Then CT scan may also be required. Important thing is that this is in absence of other causes of pancreatitis. And another important thing is, besides insulin dependent, these people have an increased risk of future pancreatic carcinoma. So that has to be kept in mind. So basically in type, diabetes in young, it may be type 1, it may be type 2, it may be MODY, it may be LADA, it may be FCPD, and it may be, MMDM also, malnutritional modulated type diabetes. Even GDM may be there, and some kind of endocrine diabetes like acromegaly. So this also is a possibility, but those are rare. Genetic syndromes, and then neonatal diabetes, that is mitochondrial diabetes. So these are all possibilities, but here the most important what I want to convey is type 1, type 2, MODY, more than 30 years, LADA, and FCPD. So these are to be kept in mind, and we should not be in a hurry to diagnose. Maybe 3 weeks to 1 month or 2 months time may be taken for the final diagnosis. Till that time, you manage with whatever medications, oral or insulin, and then once you make a proper diagnosis, then a specific treatment should be given. So basically, in all like these young type diabetes, there are 4 things which are very important. One is family history of diabetes. If it is there, it goes either in favor of type 2 diabetes or in MODY. Other is ketone bodies. If ketones are present, then basically it goes in favor of type 1 diabetes. Antibodies are positive, it's a typical autoimmune, and if antibodies are negative, it is idiopathic. But yes, in some cases of type 2, ketones may be there because of glucotoxicity. Then third important test is C-peptide levels, which are low to absent in type 1 diabetes, and they may be normal in MODY, and it may be in pancreatic as well as, and they're generally high in type 2 diabetes, but because of hyperinsulinemia, but may be normal. But this is an important test. And the fourth is an autoantibody. So once we do, go through this algorithm, take my words, most of the time, we would be able to diagnose diabetes in the best manner. So basically, overall, it can be type 1, type 2, FCPD, as well as, MODY. So this is my last slide, and the take-home message is very clear here, that that diabetes in young is not that uncommon, it's quite common. All cases need not be type 1 diabetes. there is always a diagnostic dilemma. Need to classify these, and it's not always an easy task to classify these people. Always take 1 to 3 weeks time for the diagnosis. Don't be in a hurry, because once a label is put, that label will remain, for a long time, till someone else, does a test and find out some other, kind of diabetes. Type 2 diabetes is the next common after type 1, MODI and FCPD. Accurate clinical history and examination. It goes without saying. This is an important thing which we generally miss in most of our diabetic patients. We only go with the blood glucose value and straight away start some treatment. Some biochemical test and use of an algorithm, which I've already told you. And there are challenges in management. We have to be very aggressive, because young children, they are having very poor compliance cooperation, and they're non-adherent to treatment. They do not bother about their own health because they're not aware. So education and maybe the family members and the parents should be taken into confidence to tell the severity of the disease, and then the aggressive management is to be done. Complications are more common in these, and they're more severe. So awareness, education, and intensive counseling is an important, and it will go a long way in prevention of diabetes or in best treatment of diabetes in young. So with this, I conclude my talk and I convey my thanks to all of you.
Mittal sir, it was an excellent session, very crisp and clear, highlighting the different types. You have alluded the different case series of type 1, MODI, LADA, early type 2. I think we'll take 1 or 2 questions if relevant questions are there. Okay, Mittal sir, how common is early type 2 diabetes? Before the age of 20 years, we see so many patients. How common is the early type 2 diabetes in your practice, sir?
It is very common. Recently only, I tell you, only 10 days back, I had a patient. He's still under me. Weight, is gone to from 12th class to the first year now graduation. Age is 18 years, 18 plus. And weight was 98 when he came to me. The family told me, sir, he had gone to the family physician for small fever, okay, and some weight problems. When sugar was done, it came out to be 320, the first value. Then the family physician referred the patient to me. So immediately, so this is very common now. Adolescents, like school-going children, college-going, students less than 20 years, type 2 diabetes is very common. But yes, we have to get the test done. So I did the antibodies, I did C-peptide. I'm not saying. So they were found to be C-peptide normal, antibodies negative, and patient was initially put only on 1000 milligram of metformin, and now is doing well only on 500 milligram, today. And his A1C has come down from 11.4 to now. I have advised next time he will come, but fasting is 104.
Okay, sir. Sir, in another thing in your common clinical practice, if a suspicious type 1 diabetic patient comes in, and if we are checking and the anti-GAD antibody comes as negative, would you be happy in doing other antibodies?
Yes. We should be doing, either islet cell antibody and zinc T8 antibody. So these are also important in children, because if you have a strong suspicion that it is type 1 only, then otherwise, if you think it is a type 2, then you may not go for other tests. But definitely, if it comes negative, because anti-GAD is only 65 to 70% of the patients, not in 100% of the patients.
Okay. Thank you, Mittal sir, for that wonderful session. Thank you, sir.
Thank you, Dr. Shabir, and thanks a lot, everyone. Thank you.
Okay, we will move to the next session.
Great seeing you.
We'll move to the next session, which is going to be chaired by Dr. Ramesh Gomez.
Next, we have an auspicious speaker from Madurai, Dr. Arthur Joseph Asirvatham. He is the president of Madurai Diabetes Club, and he has did his MBBS and MD from Madurai Medical College, and he has his fellowship in diabetology. And he is currently a consultant diabetologist in Arthur Asirvatham Hospital and also Apollo Speciality Hospital in Madurai. and he has got the lifetime award from Dr. Mohan's Diabetes Research Foundation, and also he is a receiver of KCP Memorial Oration Award for Diabetes. And he has got more than 70 papers in various journals. And we are lucky to have Dr. Asirvatham today. Over to Asirvatham, sir, for his presentation. Thank you.
Respected Chairman and my dear friend, Dr. Sabir, it's really a nice opportunity to be a part of this wonderful scientific event. The most unfortunate thing is I am missing his personal, what I should say, the love and affection and hospitality, which I am missing this time. However, this is in the scenario of COVID, probably this is the best that we could do. And I also thank him for giving me this opportunity, and also Novartis for having sponsored this program. So my topic is demystifying verify from an Indian perspective. So I will take you through what really is to demystify is my concept. So whether you know more about the etiology or pathogenesis of diabetes, the proof of the pudding is to give a good treatment for diabetes. And we have some amount of lack of clarity or probably inadequate knowledge, which probably we should try to get it done in a proper way and in an evidence-based manner. The pharmacological approach for management of type 2 diabetes has a few queries. Is drug combination useful? Is drug combination targeting the pathogenic mechanism? And what is the role of treatment from the beginning? Patients will always like to have some relaxation initially, and later on they would be interested in doing something. Are we justified in allowing it, or probably start the early treatment in a very intensified manner, what you call as a hit hard, hit early? So the questions posed in front of us do have an answer today, and that is my demystification. And with the evidence from the VERIFY trial, it has been proved that these combination drug has done wonders as far as a pathophysiological mechanism in producing a durable treatment, attacking the pathogenic mechanism, and also the early treatment, which has given better benefits or in the long run, which we are supposed to have for our younger diabetics, as already mentioned by my previous speakers. The concept of tight glycemic control came up after UKPDS study, and probably if UKPDS has proved that there is no point in treating diabetes to a target, all the diabetologists in the country and all over the world would have vanished. But it is very sure that glycemic control is very important. The hemoglobin A1C correlates very well with myocardial infarction or a macrovascular complication. If not with UKPDs alone, the UKPDs follow-up also showed that it correlates well with hemoglobin A1C, and microvascular complications like nephropathy and even retinopathy, they become worse the moment the hemoglobin A1C crosses 7. So that is not a difficult entity but to understand, but the onset of treatment is something was questionable, and today we have learned one more lesson as per the Diabetes Care article in 2019, wherein the literature confirms that strict glycemic control of less than 7 from the beginning or less than 1 year of onset reduces the risk of micro and macrovascular events and even mortality. So if that is possible, we should try to provide this to our patients, convincing them about a tighter control from the beginning. It is well known as far as cancer is concerned, even patients are now aware that if cancer detected early could be treated very well. So also diabetes should be identified early, treated vigorously from the beginning to achieve good control, and that would give you the benefits in due course. The results of the Diabetes Care article showed that if you have a hemoglobin A1C of more than 6.5 during your first year of therapy, it was associated with an increased future micro and macrovascular complication. But if it is going to be still high to a tune of equal to or more than 8, it indicates that you are going to have increased chances of developing microvascular events as well as the mortality. So having understood this, if you have a good study to base our status or the concept. This study again proved that when you compare two cohorts of people who have been having less than 6.5 in the first year or between 7 to 8 in the first year, with a follow-up study of about 13 years, it has been concluded that you have a reduction of microvascular complication by about 40%, macrovascular complication by about 30%, and death reduction is almost by 30% of this particular group with a 13-year follow-up. This is a very sizable reduction of all the untoward effects. Probably we are very aware of the RD sale or probably Deepavali sale, wherein some 20% discount, 30% discount on some commodity attracts our attention. So our attention should be directed towards a massive reduction of 40%, 30%, and 30% of death, micro and macrovascular complications. So if that is so, it is really worthwhile trying to make our patients come under control from the beginning. It is also understood that if you are going to at least give them some good control at some point of time, it is going to be a little more very difficult task to achieve it. At the same time, the benefit is going to be there much lesser when you start it late. So better early, the first year onwards, the treatment should be aggressive and also energetic. So that is the most important thing that we should remember. This is a very common slide that we see due to the clinicians' inertia, wherein you have a reduction of blood glucose, like exercise, diet, monotherapy, combination therapy, and finally with up-titration, and probably you need a basal insulin therapy. You already would have spent 7 to 8 years in this regard, and you would have made this patient develop some complication or other. So our idea should be like the blue line, which brings down the hemoglobin A1C straight down to 7 or less than 7, and maintain it as much as possible throughout. And this would at least give us a leash of 7 to 8 years of tight control, if it is possible with that newer concept of combination therapy from the beginning with tight control. So this is the most important message that we should try to imbibe and tell the patients and convince them to give a modality of combination therapy from the beginning. I still remember my teacher, Professor Alappan, who always used to say, you start with one drug, go up to the maximum tolerated dose or maximum therapeutic dose of the drug, and then add on the second drug, whether it is diabetes or hypertension. And this was in 1979. But today the concept has changed. Try to use combination, attacking the various pathogenic mechanism with lesser than the therapeutic dose, so that the side effects of the drugs are not seen. At the same time, you get more benefit. So this concept has been there, but do we have any evidence to do so? Say that. Now we are posed with the three important questions. Does this particular tight control from the beginning useful? And probably if it is going to be beneficial or not, and really it is quantitatively, is it going to be significant? So addressing these three questions are the concept that I'm going to prove. Now, the mist over this particular scenario has been demystified by the VERIFY study. So VERIFY study is nothing but a multinational, multi-ethnic study involving 34 countries, 254 centers, of which India also has been a part of it. And this particular study is a very simple study design, that you take the earliest or at onset or almost drug-naive patients and put them on metformin alone in the run-in period for about 3 weeks, gradually increasing the dose, and then randomize them into two arms. In one arm, you have metformin and vildagliptin started from the beginning. In the other arm, you continue only initial monotherapy of metformin and wait for what is the outcome. So when the patients are well under control with either monotherapy or probably metformin and vildagliptin therapy, we leave them at it. If there is a possibility of failure of control, which is defined by a hemoglobin A1C of more than 7 during 2 episodes of check once happening with a gap of 3 months. When you find that the patient is failing, that means you'll have to do something for it. So in the metformin arm, you are going to add a placebo. And metformin arm, you are probably going to add a vildagliptin. And the metformin vildagliptin arm, you are going to add an insulin. This is the idea. But we really do not know which arm contains which drug, the placebo or the vildagliptin. However, it is a double-blind trial. So this is the concept of this particular trial. So if this is going to go ahead, we have assessment at period 1 and period 2. So when you have this particular study, a good comparator would be an UKPDS, which studied the patients during the onset of diabetes and found that definitely tight glycemic control was better than a conventional control at the point of UKPDS as well as during the UKPDS follow-up study, which gave us a concept of legacy effect. In VERIFY trial, it is almost similar, but now that we have developed or come up in our armamentarium, UKPDS didn't have many drugs except for sulfonylurea, metformin, and insulin. But today we have got the entire area of DPP-4 inhibitor. And in VERIFY trial, we have been using vildagliptin and metformin from the beginning in one arm and only one drug at the other arm, wherein whenever there is a failure in the second arm, you add a vildagliptin as a usual pattern of adding the drug therapy. And it was found that the inclusion criteria are not very difficult, usual age, usual BMI, and the most important thing here is a hemoglobin A1C of 6.5 to 7.5. So this is not a patient who has gone out of control or hemoglobin A1C more than 7.5, wherein AACO guidelines also say that you would have to give 2 drugs. But even if the hemoglobin A1C is between 6.5 and 7.5, adding on a vildagliptin over metformin as an initial start therapy, how does it fare? That is our idea. And diabetes should be recent onset of diabetes with a reasonable amount of EGFR and a drug-naive patient. So in this particular entity, the Asian participation was also there. And among the Asian population, you have a participation of Indian population to about almost half of the Asian population. Why I'm trying to give you this particular data is that if I conclude at the VERIFY trial, you might feel that it could be a Caucasian population study, which could be either applied or could be denied in an Indian population. So we are going to discuss only on the Indian subset or the group of patients who were under this particular study from Indian origin. And probably this is what we are going to look at this particular moment. The total participants of this particular group from India was 380, and the patients who have been randomized was 163, half of them for early combination from the first day, and the initial monotherapy for another 81, almost equal arm, 1:1 arm. And all of them completed, or most of them completed 60 months. 5 years is a reasonable period for diabetes. And what is our conclusion? This is a baseline characteristics which are almost similar in the both area. And again, I am trying to tell you that the hemoglobin A1C average was 6.8 and 6.8 on both these particular arms. Left alone during my earlier phase, I would not have put them on a combination drug. I would have even put them on a lifestyle modification and waited for some time. Then added a metformin and waited for some time. But this particular concept of adding on 2 drugs at the beginning is this purpose of this particular study. And you have a drug like vildagliptin, a DPP-4 inhibitor, which does not produce hypoglycemia. So we are also safe in using this particular drug, even if the hemoglobin A1C is slightly on the lower side. And also we are sure that metformin nor vildagliptin would produce hypoglycemia. So in this particular area, what are the results that we have obtained? In the first period, what is that we have achieved? The combination, the early combination of metformin and vildagliptin failed to a particular period. Metformin alone, but it has been given with a placebo, that also started to fail at a particular point. Let us see when these two failed. It was surprising that there was a 53% risk reduction in time to initial failure versus monotherapy. So that means the combination was running like a Duracell battery, whereas the other group, the metformin and placebo group, was running like an ordinary battery. I think every one of you would have watched this ad. The Duracell battery goes on for a longer time till you see the all other batteries go off. So it is almost like a Duracell battery. This combination is wonderful and existing under good control for a longer time when compared to monotherapy, with a good reduction of hazard ratio. And it was found that monotherapy lasted only for about 1.5 years. And this also was proved by UKPDS that lifestyle modification metformin was useful only in 1/3 of the people and lasted only for a short while. The combination therapy was there till 4.75 years. That is most wonderful evidence to say that if you put this particular patient on this combination from initial period or at onset, you'll be able to give them a trouble-free period. And as I showed you, the blue line which came down straight away and maintained on the same hemoglobin A1C, you're able to provide a good hemoglobin A1C from the beginning, thereby giving a good legacy effect, good hemoglobin A1C control, and probably freedom from complication and mortality. So that is about the duration of study, and this happened earlier in the Indian subsets because we probably have little less insulin secretory capacity. But in spite of this particular 4.75 years of usefulness, that is not the end of it. Diabetes is a progressive deteriorating disease wherein the beta cell mass goes down. So what happens beyond this particular area, wherein in the period 2, where the combination also starts failing, then you realized that you have to have an insulin as per the protocol. On the other arm, the comparator arm, what you really identified was, even though you added a second drug early, that was not equal to this particular arm. That is the most important second message I would like to convey. You are ultimately putting this patient on metformin and vildagliptin. If you have added it on initially, that gives you more benefit when compared to adding on same vildagliptin later on after some monotherapy of metformin in due course. So comparing these two arms, what is our conclusion? It was really an amazing fact that the starting early with vildagliptin and metformin reduces the risk of addition of a third agent by 58, almost 60%. That means if you are controlling diabetes, the legacy effect happens, the beta cell probably recovers, and that is able to sustain it for a longer time. Thereby, the need for a third drug is going to be reduced by about 60% in due course when comparing the arm in which both the agents have been started early and in the other arm, control arm, wherein metformin was initially on board, you added vildagliptin later, but though both the drugs are there in both the arms, the benefit was much more when it was started quite early with a hazard ratio of 0.42. The next important message is that, as I showed you the blue line which dwindled down drastically and maintained with a durability, you see here almost 75 to 80% of the patients on this particular arm, the arm which both the drugs have started early, had a hemoglobin A1C of less than 7 throughout the study of 60 months. That is really remarkable. So maybe for 20% of patients, we may have to add a third drug like an alpha glucose inhibitor or some other drug like SGLT2. But on the whole, if 80% of the patients are under control, maybe the window shopping of these patients to some other diabetologist would also not happen in 80% of my patients. So in that way, the diabetes is stable, diabetic patient is stable, and the diabetologist also are stable. So that is a good message for all the three of us. And with this particular good news, I am trying to conclude with a key finding that early combination treatment almost reduced by 50% to the risk of time to initial treatment failure. That is, you need not wait for the failure to happen and then go ahead. You can almost fit and forget for 5 years in most of the patients. The mean time to initial failure was 1.5 in the initial monotherapy compared to almost 5 years, 4.75 years in the early combination or de novo combination therapy. When all patients were receiving combination therapy, in one group it was started early, in the other group it was started as a measure or a rescue measure as an add-on to metformin on top. When you had that, the risk reduction was around 58%. So finally, the strategy of early combination treatment approach with vildagliptin plus metformin in the newly diagnosed patient significantly and consistently improves long-term glycemic durability compared to metformin therapy. So, dear friends, we now have an evidence to start this combination quite early to give our patients a good, durable control and a complication-free control. Thank you very much for your patient listening and for the nice opportunity. I sincerely thank Dr. Sabir once again. Thank you.
Thank you, Dr. Asirvatham, for that
Thank
excellent
you very
topic.
much. Thank you very much.
Real demystifying process. Thank you. And next is
Thank you.
Dr. Rama Mohan MV, Senior Consultant Endocrinologist. He is a Senior Consultant Endocrinologist.
Good evening, everybody. I sincerely thank Dr. Shabir sir for giving me this opportunity, and it was pleasure last year meeting all the eminent speakers in Kerala, and we had a very great time there with scientific feast and also had a temple tour there, and so I would like to today's my topic is glycemic monitoring and management of type 1 diabetes. What are the challenges and solutions? I want to make this topic very simple. We know that type 1 diabetes is a very dreadful disease, and all the kids whom we love, whom are able to take insulin by themselves and who has different difficulties for the lifelong to take insulin, and all these things also will pose a great psychological, financial stress to the families also. So coming to the challenges, what we face in treatment of type 1 diabetes. So I would like to divide these challenges into first challenge will be about HbA1c control. Second challenge will be about prevention of hypoglycemia. Then coming to the how to monitor the glucose is also a big challenge. Then what is the diet pattern of the kids, and it is the most difficult thing to control is the diet pattern in the kids who we are unable to stop the snacking, junk food intake by the kids, and then comes the exercise pattern. So we adults don't do exercise, and we expect our kids to do exercise, which is very difficult. Then coming to the sick day guideline challenges, adolescent transition challenges. So when the type 1 diabetic people turn into from kids to adolescents and adults, what are the challenges? And then prevention of complications is also a big challenge in type 1 diabetes. So we know that type 1 diabetes can present like acute onset type 1 diabetes discovered accidentally by doing RBS for other region, like a life-threatening DKA, flash DKA can also occur. Patients can also have subclinical diabetes precede the clinical onset. What are the four major clinical phases of the preclinical diabetes? We have over diabetes and partial remission or honeymoon phase, then a chronic phase of lifelong dependency on insulin. And clinical onset is not likely to occur until major loss of around 80 to 90% loss of beta cells has been occurred. So coming to the classification, we have type 1A and type 1B diabetes. Type 1A is about patients having autoimmune positive. We have 4 autoantibodies like IAA, IA2, zinc transporter, and GAD antibodies. And we have type 1B, where around 10% of the type 1 diabetic patients will be negative for all antibodies, but still they have a insulin deficiency. Then comes the type 1.5 or double diabetes, where we have both autoantibodies and islet cell resistance. Insulin resistance also occurs. Coming to the management needs a multidisciplinary team. It's not about only one endocrinologist or a pediatrician to take care of the type 1 diabetic kid. We had to have a multidisciplinary team of pediatrician, endocrinologist, diabetes nurse educator, dietitian, social worker, psychologist with a family care. So what are the principles of management? The principles of base management is on insulin use. We have diet regimen, a regular exercise, physical activity, and then we go for monitoring. So first challenge is HbA1c. See, adequate glycemic control, avoiding hypoglycemia is the major goal. And what is your HbA1c goal in kids? So previously, we used to say that with toddlers and preschoolers, to prevent hypoglycemia, the FBS should be between 100 to 180, PPBS should be between 110 to 200. So HbA1c less than 8.5. From school age, 6 to 12, 90 to 180 is fasting, PPBS is 100 to 180, and HbA1c is less than 8. Adolescents and young adults, we have fasting of near adult range 90 to 130, 90 to 150 of postprandial, and HbA1c of less than 7.5. So, but coming to a summary, if there is no impedance for hypoglycemia, or if the kid is cooperating very well and the sugars are under control, your HbA1c target should be in any kid should be less than 7.5. And if they are facing any other problems of hypoglycemia, recurrent hypoglycemias, then you can keep age-related targets of HbA1c. Then choice of insulin delivery, we have multidisciplinary, multiple daily injections and continuous delivery of rapid acting insulin via pumps. So how to reach this HbA1c control is by this mechanism, and mainly glycemic control generally similar with both multiple injections and continuous subcutaneous infusion, but only less number of nocturnal hypoglycemias occur with CGM. So multiple daily injections, which we commonly use, we have a basal options. We have NPH, Glargine, Detimer, and Degludec. Prandial insulin, we have regular aspart, ultra-fast acting aspart, Lispro, and glulysin. So we tend to mimic the physiological insulin secretion in all the kids so that we are making the kid as normal as possible. So this chart everybody knows. We have a basal insulin with meal-related peak of insulin secretion, which we tend to use by basal bolus regimen. So other challenging is about the insulin injection site. See, last week I had a type 1 diabetic patient who is coming first time to my clinic, and I was astonished to find there are large abscesses over the forearm and in the upper arm regions. Saying that what has happened, he is saying that he was taking insulin in the forearm and upper arm regions. Saying that not only prescribing insulin and making the kid to take the insulin, to rotate the areas of insulin injection is also important to prevent lipoatrophy and lipohypertrophy, and to have a erratic hypo and hyperglycemias in these kids because of this lipoatrophy, which is making the insulin absorption in an erratic way. So we have to explain your kids, and I have to make the kids to take insulin in front of you so that they'll learn better. Then coming to the second challenge, hypoglycemia, our goal should be to prevent hypoglycemia at any chance. So you know how dreadful it will be to see the parents having their kid in hypoglycemia, patient with unconscious state, patient with drooling saliva, and patient throwing fits if encephalopathy is there. Like that, this will be dreadful to the parent, and they will be very afraid of the insulin also. So at any cost, we have to prevent hypoglycemia in kids. Mainly, we know that this continuous glucose monitoring system will help to reduce hypoglycemias in our patients. So there is also chance of patients getting into hypoglycemia associated autonomic failure. We know that recurrent hypoglycemias in a patient will lead to autonomic failure, will lead to less concerned about the hypoglycemia, and there will be unawareness of hypoglycemia, which will also be giving a problem to the patient because they are unaware of the hypoglycemia. So every kid, you have to tell them that the clinical symptoms of hypoglycemia, if they have any sweatings, if they are missing any meals, if they are missing any snacks in their school, they should be knowing about the hypoglycemia risk. And if the kid is going to the school, you have to tell to their class teacher, their class leader, and to the headmasters, so that they'll be knowing what to do first aid in hypoglycemia, acute hypoglycemia occurring in a school, so that the first aid can be done and the baby can be saved from severe hypoglycemia. So the solution is minimize hypos, and continuous monitoring and education is also very important. So coming to the third challenge, glucose monitoring, how to monitor the glucose in type 1 diabetic patients. We know that home glucose monitoring system, ideally more than 4 times a day is advised in all type 1 diabetic patients, but it is very difficult for any type 1 diabetic patient to look 3 or 4 times blood glucose in home and to report to you. But minimum of around at least twice or thrice a month, take pre-breakfast, pre-lunch and pre-dinner and bedtime. They make a chart of it so that they'll come back with the reports to you, so that you will find out how the trend is going on, whether they are going for hypoglycemias or hyperglycemias, are there any extreme excursions of the glucose, blood glucose levels without knowing to you, and you want to change any doses, you'll be knowing properly. So we know that intermittent blood glucose monitoring is like taking a camera, because you know the snapshot which happened at that point of time. For example, if you check a blood glucose fasting, you'll be knowing fasting sugar. If you do a blood glucose at 11 or 12 a.m., you will 12 p.m. or 11 a.m. you'll be knowing pre-lunch breaks of sugars, but you don't know what is happening in between. So continuous monitor is like a camera which captures the whole picture like a video. You know what is happening in continuous way, so it gives a more advantages of glycemic excursions, how they are happening, and you want to keep your blood sugars in time in range. This continuous monitoring helps well. So it is hard to be good at all time. You can see that you can see that 6 a.m. fasting is around 130, 12 p.m. fasting is around 130, again at 7 p.m. 7 p.m. it is 90, and around at 10 p.m. it is around 150, but 140. But if you see, due to erratic food eating behaviors in this kid, you can see the CGMS is entirely different. So it is like you can compare the camera that shots with a continuous glucose monitoring. Here it shows how erratic it was, and when you see the multiple parameters, they are normal, but the CGM is different. So that the benefits are, compared to SMBG, CGM reveals dangerous glycemic excursion. Thus, real-time data allows the patient to intervene and optimize the outcomes. This is the best thing you can do in a type 1 diabetic kid. So we have newer technologies. We have a sensor, we have a transmitter, and we have a monitor for CGMS, and we have a closed loop and open loop system. The future is we are having insulin injections and episodic glucose monitoring. We'll go ahead with insulin pumps and continuous glucose monitoring. Our target is artificial mechanical pancreas. And you know that first insulin pump, how much big it looks like. You can see here in this picture, and in continuous subcutaneous insulin infusion, we have a choice of insulin of rapid acting. Initial dose will be there, basal rate and bolus dosing can be monitored. And we have two types of pumps. We have hybrid closed loop system and automatic closed loop system, which detect the hypoglycemia and they themselves give the bolus also. So we should think like pancreas. So that means how our pancreas works in a normal person. So that if you think like pancreas, then your type 1 diabetic patient will be safe. So you also should keep in your mind that most of the children who came at the time of diagnosis will go into honeymoon period. That means, for example, after treatment of 1 to 2 months, suddenly drastically the use of the doses of insulin comes down to less than 0.5 units per kg from 1 unit per kg, and it stays for about around 1 to 2 months or up to 2 years duration in some patients. But you never miss the insulin in them. You try to give low dose insulin treatment, observe the patients so that they never go again into DKA. This occurs because of the honeymoon period, is because of that glucose stunning and that pancreatic beta cell stunning. There is a mild recovery of your pancreas, so that some of the insulin is produced more, and the patient's going to honeymoon period. So you have to keep in mind this also while you monitor type 1 diabetic patients. Then coming to the fourth challenge, it is diet. So what is your goal? You should give every type 1 diabetic child a balanced diet. So to remain ideal body weight, to promote growth, the main aim is to have 3 main meals and 3 mid-meal snacks. So you have to have a good carbohydrate, protein and fat ratio, and you should have a good fruit amounts and vegetables snacking amount should be there. You can ask your kid, or you can ask your parent to count carbohydrate count if it is possible to them. You make the child and parent learn about the need for fruits and vegetables, amount portion in your plate, food plate, so that they never going for uh, unhealthy snacking. And ask the kids to stop taking uh, junk foods, cool drinks, or beverages which are high rich in sugars. So then coming to the exercise, the goal is to keep fit and healthy. So exercise, physical activity, children should be encouraged to participate in all games and sports activities, and you should have a simultaneous glucose. It stimulates the glucose uptake into skeletal muscles, plays a very important role in management of diabetes. It occurs. It does a good work in, so if physical activity or physical exercise does benefit your kids much very well. But you should ask, when the kid is going for a strenuous exercise, you should ask the kid to have a small snack so that that kid doesn't go into hypoglycemia. So risk of hypoglycemia with vigorous exercises occurs. So extra carbs should be given to the kid before exercising. So then coming to the sick day guidelines, main goal is to prevent ketosis or DKA, prevent dehydration, prevent ketosis, or prevent hypoglycemia. Sorry. So ketonuria or ketonemia suggests either insulin deficiency or kid is starving. You should see in these patients. And any infection in diabetic child can precipitate DKA. Maintain dehydration at home, frequent blood glucose monitoring at home, and check urine for ketones. If positive, will need more short-acting insulin. And hospitalization if ketonuria or hyperglycemia persists or patient develops persistent vomiting, so that you have to treat this acidosis as fast as possible. So next complication is challenge is prevention of complications. We know that the most common complications are acute complications like is there and have an impact on growth. The patient is having poor glycemic control, and patient will be having impact on growth and puberty also in type 1 diabetic kids. So complications, long-term complications, we have nephropathy, retinopathy, neuropathy, and limited joint mobility. We know that indications for screening all the neuropathy at the start of puberty are more than 10 years, which is earlier. Once diabetes duration is more than 5 years, you have to screen every kid for all these complications, and look for hypertension in type 1 diabetes. Measure BP at every visit. Use a children cuff which is probable for your kids. Now, don't use adult BP cuff. It gives a false BP readings. And target blood pressure should be less than 130/80. Then coming to the dyslipidemia. So any family history of CV events or family history of unknown hypercholesterolemia, fasting lipid profile more than 2 years of an age should be diagnosis, and family history is unremarkable. Do a lipid profile more than 10 years. Diabetic diagnosed prior or post puberty, post diagnosis immediately do a lipid profile. So don't miss this also. So coming to the other monitoring areas where other complications like other autoimmune diseases associated with type 1 diabetes. We know that autoimmune thyroid disease is highest thyroid disorder, highest autoimmune disease associated with type 1 diabetic patients. You have to look for TPO antibodies or thyroglobulin antibodies. It is around 25%, and more than 10% of our kids go into hypothyroidism, overt hypothyroidism. In my opinion, every type 1 diabetic kid at the time of diagnosis should be looked for autoimmune hypothyroidism. And coming to the celiac disease, which is like a very bad disease, but it is not often looked properly. You should look for malabsorption in any kid. You should look for fragile glucose control in any of your type 1 diabetic kid. Erratic glucose readings in your kid which are not up to your expectations. Then you look for celiac disease. Ask for any gluten hypersensitivity, gluten sensitivity. Then do a tissue transglutaminase antibody test in associated with serum IgA levels. And this is as high as around 18% in our population, and around 10% of type 1 diabetic kids going to celiac disease also. This is also not looked properly by all the diabetologists and endocrinologists. So coming to the adolescent transition, we know that every kid should go into smooth transition from children and adolescents to adults also. Changing insulin sensitivity related to sexual maturity and physical growth occurs because during the puberty there is a surge of hormones which are against insulin. Insulin is one way, anabolic hormone, other catabolic hormones like cortisol, growth hormone, you have testosterone, all these things are in the other side of your balance, so that you should have a these hormones tend to increase the insulin sensitivity, tend to decrease the insulin sensitivity, tend to increase your insulin resistance in these patients, and ability to provide self-care. They should know about their own self-care. Should be able to take insulin by themselves, and education is also important. Supervision in child care and school. Unique neurological vulnerability due to hypoglycemia and DKA should look in adolescent population. Then attention to family dynamics, developmental stages, psychological, physiological differences related to sexual maturity is an essential thing. So all teens transiting into emerging into adulthood, healthcare providers and families recognize their many vulnerabilities and prepare the developing teen to become adult, and also see that these people are given good education about their disease 1 year prior to the transition, and both pediatricians and adult healthcare providers should be assist providing support and links to resources for the teen and emerging adults. So I would like to conclude that in type 1 diabetes we have very number of challenges, and how you approach these challenges will make you successful, and so that your type 1 diabetic kid will be healthier and will be having a good lifespan without any complications. So you should never forget all these 8 challenges which you face commonly in all type 1 diabetic patients, so that you get a definite benefit in treating your type 1 diabetic patients. So I'd like to conclude this by saying that monitoring and targeting all the HbA1c levels in your type 1 diabetic patients is major role, and so if you follow all these challenges and if you find all the solution to the challenges, your type 1 diabetic kid will be at a healthy state. Thank you.
Dr. Rama Mohan, glycemic monitoring and management of type 1 diabetes, the challenges and solutions. Thank you, Dr. Rama Mohan, for an excellent presentation. Actually, it was very crystal clear. One question I would like to ask is, how often you have to prescribe oral hypoglycemic agents for your patients with type 1 diabetes for one or other reasons?
Oral hypoglycemic agent, am I right?
Yeah.
Yeah, see, generally, most of my type 1 diabetic patients, when they become little obese in the teens, I use only metformin in them, but it also doesn't work well. I go around 1 gram per day to decrease the insulin doses up to 10 or 15 units per day. But some patients it works well, but other patients doesn't work well. But we never use any other oral medications. Only in teenage group, as I told you, to reduce the insulin resistance, I used metformin. Other than that, I never used any drug, and they won't work. If that kid is a type 1 diabetic kid.
Thank you.
And using Oglibos, we have some also use Oglibos or Acarbos, but these people are kids, and the tolerability is also a very issue, and their eating habits, and we had to look into that. But around 1.5% of decrease in HbA1c seen with Oglibos in type 1 diabetes. And we have upcoming data about SGLT2 inhibitors, and we need time for that to come true, and we have to look for decay in these patients also.
Thank you.
Okay, thank you, sir.